Jason, what's your opinion on the use of IDO inhibition? I mean, there have been at least 2 or 3 trials, small phase 1 and 2 trials, of either indoximab or epacadostat, both IDO inhibitors. There are data suggesting that IDO inhibition is an immunosuppressive, or it's potentially a way to overcome immunosuppression independent of checkpoint protein inhibition. What do we know about those phase 2 trials now? I guess they're in phase 3.
Yep. So I think to build on things that other people have said, I think the model that we were sort of building about how to develop these combinations in sort of a more rational fashion is really kind of taking the idea of whether or not the immune cells are present or they are not, and trying to harness that knowledge into deciding which combinations to give. Because if there is a robust microenvironment that has immune cells in it, several of these approaches of hitting multiple checkpoints in the tumor microenvironment are likely to be effective. And so you mentioned indoleamine dioxygenase, or IDO, which is another putative checkpoint. It's a metabolomic checkpoint in combination with PD-1, where at previous meetings we've seen that the response rate has been elevated up over 55% with minimal, if any, increase in toxicity relative to the monotherapy PD-1. So I, in fact, think that actually is the most exciting combination that's coming forward. You reference how it's gone into subsequent trials. We participated in that trial in the phase 1, and it went from phase 1 trial to phase 3 trial, accrued very, very rapidly, and we're now basically waiting for the results. I think that if the results look anything like what we saw in the preliminary data set, it will be a very attractive combination with an increase in response rate. If those responses are like what we've seen with pembrolizumab now at this meeting, they will likely be durable, and if there's no increase in toxicity, that would be quite attractive. So I think that that's in the hot tumors. LAG-3 also might go with hot tumors because it's on T cells, and there are others that go with that. But then the flip side would be what's just discussed here. Those patients do not have immune cells in their tumor. We got to get them there somehow. Best way to get them there is innate immunity, and that could be a virus, it could be a toll-like receptor agonist, it could be a STING agonist.
And there are at least 3 or 4 trials, I gather, of either pembrolizumab, nivolumab, or atezolizumab with a TLR9 or TLR4 agonist. So do you see these as making a cold tumor hot?
Absolutely. But I think the broad concept is bringing in the innate immunity. Will oncolytic virus be better than TLRs, be better than STING agonism? We don't really know those answers because they're too preliminary. I think the data set for some oncolytic viruses is the furthest clinically developed, but the biology and the framework that I'm talking about, I think, can really guide these clinical trials to be more rapidly successful as opposed to just treating all patients.
Okay, but here's the development conundrum. You have an active drug, pembrolizumab, with a 42% response rate and a 33% median survival. You're going to add drug X to it. Drug X has no independent anti-tumor activity. So you're forced to do a randomized trial, but and in general, I assume in a randomized trial, it's the number of events that has to occur to see a difference between arm A and arm B, but won't we be waiting for years with these IDO trials, Georgina?
Well, it depends on the endpoint, which goes back to my point about the progression-free survival versus the overall survival. So if you're talking about events being progression events, yeah, we may have to wait a little longer, but I don't think years. If we're talking about survival events, yeah, we'll be waiting a long time.
Well, yeah. Will the FDA or the Australian authorities or the EMEA, will they allow progression-free survival to be used as an endpoint for registration?
I don't know, but I think we're really going to have to change the paradigm as we get more sophisticated in terms of understanding the biology and then translating that directly and seeing exactly what we hypothesized. I mean, this last decade has seen that time and time again, even in lung cancer and ALK inhibitors and the immune therapies. It's amazing that we had a hypothesis, we do it, and wow, it worked. So I think we have to change our attitude, but I would propose that we need to consider the landmark progression-free survival. We're in it for cure. I think melanoma is different to solid tumors, and maybe the whole cancer field of solid tumors is shifting because it's been a desert for us, and all of a sudden we have these active treatments. As physicians, cancer physicians, we're a bit different. We're like hematologists. We're going for cure. And so what we're after is this tail and getting that tail higher. And I think the best way to measure that, the quickest way at this point in time, would be landmark progression-free survival. So yeah, we'll have to wait a little longer, but not that long. I think overall survival's hard, and we should get on with it and do these trials. The trick is choosing the right combinations and not wasting time, effort, and money in clinical trials, multiple, and wasting patients.
Because patient resources are limited. We now have so many trials, we don't have enough patients to put on them.